All right, so let's get into it. Hopefully, we won't be here as long, but I do want to make sure I get as much information for you guys as possible. Okay. We have two chapters, but tonight we're going to be looking at diseases of the circulatory and central nervous systems. The mini session is up, chapter 18, diseases of the skin and internal tissues. Okay. Now, some of the things that you're going to see in the mini session deal with some of the images that you see in front of you. Okay. Now I'm going to go ahead and let you know which one is which. Time purposes. I know that it is the night before we all get together. So we're looking at the image of the patient with macropapillary and pedicle lesions from the mini session, which is actually this one. Okay. This is a child with macropapillary and pedicle lesions. Now, A is the right forearm. It has a cluster of boils that are caused by Bacillus anthracis. And what you see over here in C is what's called pyoderm gangrenosium ulceration. And this is of the left lateral upper arm that has a positive finding of Pseudomonas infection. So, in that mini session, you're going to get a lot of information on these three specifics. Not only these, but it'll kind of break down this information for you. So, if there's anything in that in that mini session that kind of like stands out, just reach out and let me know, and I will try to break it down for you. Now, again, today we're going to specifically look at diseases of the circulatory and central nervous systems. So that means that we have to define key terms. We have to discuss the mechanisms of contamination of blood products. We have to identify the pathogens associated with infections of the cardiovascular system as well as the central nervous system and describe the various infections caused by pathogenic invasions of the structures within the cardiovascular and central nervous system. Now, the cool thing again is there's always some type of clinical significant topic. And this week it's on bloodborne pathogens and safety in the operating room. So, as surgical techs, we have to protect ourselves and, of course, others by using sharp safety and personal protective equipment at all times. Okay. Now, with the term standard precautions that you're going to hear a lot, we're treating every patient as if they could have the entire infection of Earth. So, safety practices are always followed by hands-free or neutral zones where we pass sharps, using no touch technique, choosing blunt suture needles, and then wearing eye protection and PPE consistently. Now, all of these steps help keep everyone in the operating room safe, including the patient. All right, now back to chapter 17. We start off in the chapter talking about hematology. That's just the study of blood. Now, your white blood cells are your leukocytes. They fight infection. Your red blood cells are your erythrocytes. They carry oxygen and carbon dioxide. And then there's platelets or thrombocytes, which really just help stop bleeding. What you want to know is that the composition of blood is 55% plasma, which is mostly water, proteins, vitamins, and salts, and 45% cells, red, white, and your platelets. Sometimes we have what's called centrifuge blood, where cells sink plasma, and then what you see, or the cells will sink, and then the plasma kind of stays on the top. That's what centrifuge blood is. When we look at whole blood versus serum, now your whole blood is your plasma and your cells. Your serum is that clear liquid that you guys will see after clotting, where it contains antibodies that is used for testing. Now, with any type of blood transfusion, there is a risk, but we're giving these blood transfusions that are usually safe and life-saving. But again, there is that small risk of infection if the blood is contaminated. Now, there are harmful pathogens that can sometimes be passed through transfusions, like they spread in other ways. Bacteria like Staphylococcus aureus or Staphylococcus epidermidis can come from skin during needles, like a needle stick. Parasites, like those of malaria, um, can also happen. There's viruses including Hep B, Hep C, HIV, West Nile, and Zika. Again, these are rare. And then prions. These are the rare prions that cause Creutzfeldt-Jakob disease or CJD. Good thing is that there is strict screening and testing, so the chance of getting an infection from a transfusion is actually very low, but we still talk about it because it's not zero. Now, when we look at bacteremia, bacteria that's actually in the bloodstream, it's caused by minor skin injuries. It could be surgery, it could be trauma or infections that can spread. It can also happen after using catheters, implants, or unfortunately from post op wound infections. Now, with septicemia, this is a more serious body-wide systemic infection. It's a severe form of bacteremia where the infection will spread and cause a full body response. Symptoms may include fever, confusion, rash, like a rapid heartbeat, and a low blood pressure. Unfortunately, it can lead to septic shock, which, as we know, is life threatening, especially in patients with already weak immune systems. So, some of the causes, especially when the lungs, streptococcus pneumonia or chlamydia pneumonia, if it's in the GI tract, we're looking at E. coli or Bacteroides fragilis. If it's a skin or tissue, it could be Staphylococcus aureus or Pseudomonas. Urinary tract, there's that E. coli or Klebsiella. And then when we talk about the brain or central nervous system, we're talking about Staphylococcus pneumonia or Neisseria meningitis. With infective endocarditis, now we're talking about bacteria that infects the heart valves. With subacute, i.e., ineffective endocarditis, it develops really slow, often from like an oral bacteria like Staphylococcus aureus or Staphylococcus pyogenes. And then there's acute IE, happens quickly and is more aggressive. Now, patients with heart conditions may get antibiotics before they have, like, let's say, dental work, like an extraction. And that's just to prevent bacteria from entering into the bloodstream and really infecting their heart. Bacteria from IE can cause dangerous blood clots that will travel to the lungs or to the brain, leading to serious complications. So let's look at something. Now, again, we know that IE is a serious infection. Okay. It can harm the inner lining of the heart or the endocardium. And that's going to be what's affecting the valves. This can lead to valve problem where there's valvular insufficiency, so the valves aren't closing and opening like they're supposed to. And it can cause, unfortunately, congestive heart failure or even abscesses in heart muscle. Without treatment, again, IE can be life-threatening. Now, who's at risk? It's going to be patients with damaged or abnormal heart valves already, and then people who engage in IV drug use or unprotected sex. Patients who have infections elsewhere or experience trauma that allows the bacteria to enter the bloodstream are also at risk. The crazy thing is, bacteria that enters the bloodstream can actually settle on the heart valves, and that's what leads to severe illness or death if it's not treated early. So that means that early diagnosis and antibiotic treatment is going to be what's important to prevent long-term damage. Now, with group B streptococcus, it is a type of bacteria that adults can carry without even knowing it. It's usually harmless to the mother, but it's so dangerous to newborns. It can cause serious infections like sepsis or meningitis. I want you to think of GBD as that quiet rider in the mother's body that can turn harmful when it passes to a baby. For us, we just have to be aware especially if you guys are working in OBGYN, and it's a suspected during a delivery. So very strict surgical technique, especially when assisting in childbirth. Yes, we can assist in childbirth. Um, because it can be passed to the baby during a vaginal birth. Even moms who don't show symptoms can pass it on. Now, we look at acute infective enteritis. Again, I mentioned it's fast acting. It affects the healthy heart valves. It's usually caused by Streptococcus aureus or group B Streptococcus, kind of like what we just saw with the infant. It comes on suddenly and can be quickly to damage the valves, and it's often fatal without treatment. This is when the bacteria is getting into that bloodstream from other infections or trauma. There's also the chapter wants us to know about prosthetic endocarditis or prosthetic valve endocarditis, PVE. This happens in patients that already have artificial heart valves. Okay. It can be mechanical or bioprosthetic. It makes up about 5 to 10% of IE cases. Mechanical valves have a higher risk of infection in the first 3 months or early onset, whereas a bioprosthetic valve is most likely going to have an infection after 1 year, and that's considered late onset. The other thing to know is mitral valves are more often affected than aortic valves, and it's caused mainly by Staphylococcus aureus, but other bacteria may also be involved. Patients with pacemakers or even defibrillators also face similar risks, and we can't count out IV drug users. This is a common cause of IE. About 75% of cases involved in native heart valve issues. The tricuspid valve is affected by 50% of these cases as well. But there's also fungal infections the chapter talks about, like Candida albicans. It's more common though in those IV drug users, ICU patients that are on strong antibiotics, and remember their bodies are already weakened. Okay. Now, the thing is, fungal infection doesn't always show up in blood tests, which is really important. That means diagnosis may require examining tissue samples like emboli, where they're going to look underneath a microscope just to kind of like verify, is this really a fungal infection? Okay. Now, the biggest thing to know is that we have to understand the different types of IE and who's most at risk. Once we know that IE is either bacterial or fungal, then it can have an effect either natural, or we know that it can affect the artificial valves. And the biggest thing is early detection and treatment are critical. These infections are life-threatening. Now, why is anticoagulation usually given to patients who have or patients who receive a mechanical valve? Now, the one thing to keep in mind is that anticoagulation is almost always required for patients with mechanical heart valves because of how the valve is built and how the body just naturally responds to it. So I want you to think of it in a way that mechanical valves are going to have some type of foreign surfaces that unfortunately can attract a clot formation. So these valves are going to be made up of like metal, or some are carbon materials, but blood tends to form clots when it touches anything that is just not natural tissue. And then you'll start looking at, okay, a clot can actually form. So it's one of those necessary evils, if that makes sense. Like, we need to get this valve in, right? We also know that it could potentially have a clot. So we're going to go ahead and give it and kind of like just monitor them. Does that make sense? Awesome. Okay. Now, What do we need to know? So let's say the patient has a heart murmur, which is very common. This is a clinical sign. It's found in about 85% of IE cases. And of course, it can be heard with a stethoscope and it'll have like an abnormal heart sound. Classic physical signs are seen in about 50% of patients. Tiny clots or red streaks under the fingernails or toenails can be seen. There's pediculi, which are the small red or purple spots on like the skin from like bleeding underneath a surface. And there's also what's called Janeway lesions, the book talks about, that are painless, red or purple spots on the patient's palms or the soles of their feet. There's also ulcer nodes. These are painful raised bumps on the fingers or toes. And they may even have Roth spots, which are very rare, but they're spots with pale centers that are actually seen in the retina of the eye. But there are other symptoms to kind of just be aware of. So there's neurological symptoms that mirror stroke-like symptoms. So the patient may present with paralysis, weakness on one side, they may have confusion or stiff neck. And on the cardiovascular side, they may have like swollen neck veins. They may have an irregular heartbeat or signs of heart failure that can be seen on imaging. They may even have an enlarged liver or spleen. They may have what's called gallops or rails, or it's like a rubbing noise from inflammation that can be heard in the heart or lung sounds. Treatment is going to be antibiotics. That's the first line. That's to try to fight the infection. Now, when they come to us, that's only as needed. And that's because they need to have the removed tissue or the infected tissue removed, repaired, or they have to get a heart valve replacement. And sometimes they'll go in for a lysis of adhesions where we're breaking up those adhesions that were formed. And then there's supportive care. Heart failure may require, of course, medicine. They may come to us. They may have oxygen therapy, dialysis if the kidneys are actually infected. Now, with myocarditis, this is the actual inflammation of the heart muscle. So you see on the left side a healthy heart, right? And on the right side, myocarditis, where you see the inflammation of the heart's middle layer. That's the actual muscle layer, and it's usually caused by some type of infection. So there's common causes. There is bacteria like chlamydia, streptococcus, staphylococcus. There's viruses, hep C, herpes, HIV, parvovirus. There's even fungi. Cryptococcus and coccidius are some of the ones that cause it as well. Now, it's hard to catch. And the reason why it's hard to catch is because the symptoms are often so mild or not even noticeable, which makes it hard to diagnose early, which is what we want to do. Some people may not even know they have it until more serious problems develop. Now, this is important to us because myocarditis can lead to cardiomyopathy when the heart becomes weakened and then it's just not pumping blood properly. This can result in heart failure or the need for a heart transplant. In the United States, myocarditis and cardiomyopathy are major reasons that patients need heart transplants. Now, even though it may seem mild at first, myocarditis can lead to serious life-threatening heart damage if it's not treated. And this is why early detection and early diagnosis is really important. Now, we get into pericarditis. Now we're talking about the inflammation of the outer heart layer. Okay. It can be mild, long lasting, or life threatening, again, if it's not treated early. This is caused by bacterial pericarditis, usually is caused from bacteria like pneumonia, lung abscesses, often streptococcus. There's also acute viral pericarditis that's caused by viruses, but it is less common. Chronic pericarditis leads to adhesions or scar tissue between the heart and the pericardium. And then sometimes they have to come to us for lysis of adhesions to kind of break up that scar tissue. There's also tuberculous pericarditis, the chapter wants you guys to know about, where I want you to think of a tightening. So if you ever think of a burn victim, and if they have a full chest burn victim, a lot of times we're going to cut slits in the skin so that it doesn't tighten up and their lungs can't expand. Well, a tamponade can happen with the heart as well, where and the cardiac tamponade is the same thing. It's like a squishing or pressure around the heart, and that's the thickening of the pericardium. Okay, and that's what causes that cardiac tamponade. This is a life-threatening condition because there's fluid that's building up around the heart and preventing it from pumping proper. It's like it's squishing it to the point where the heart is not able to move. So there are treatments for pericarditis where we'll take a needle to kind of drain the fluid from the pericardial sac and relieve the pressure. And then, of course, surgical lysis of adhesions, where we'll go in and break up that scar tissue. And this is going to be for chronic cases, just to really free the heart and allow it to pump freely. There is vasculitis or angiitis. Now we're talking about inflammation of the blood vessels. Now, it can lead to reduced blood flow or narrowing. It can lead to blocking, causing ischemia or tissue death, or widening, forming an aneurysm. The cause, um, it can actually cause painful skin sores that turn black from tissue death. It produces a blue colored pus because of the pigment called pyocan. And it's seen often in neutropenic patients, and these are patients with low white blood cells. Um, and again, another issue is it can be life threatening. Okay, I feel like all of these have that life threatening if we don't get to them soon enough. Now, how is this related? This is found in deep wounds, fractures, our burn patients. It can cause the bone infections or osteomyelitis. It is linked to prosthetic heart valves. IV drug use will actually increase the risk of infective endarteris. Now, there are types. The chapter wants you guys to know. Right-sided, it's going to be usually in younger or otherwise healthier people. It often affects the tricuspid valve. That's the right side. The left side is more serious. It's often with worse outcomes. Now, keep in mind that vasculitis can damage organs because of the poor blood flow. Infections from Pseudomonas aeruginosa have to be identified and treated quickly, especially in our patients that are already immunocompromised, our burn victims, and patients with like implants or catheters. Now, for us, we need to just recognize the signs because it is a dangerous infection that is caused by like Pseudomonas. And we have to understand how blood vessel inflammation affects just our patient surgical healing and their outcomes. Now, one of the big things we talk about is the blood-brain barrier, the BBB. This is the brain's protective shield. It protects the brain by blocking harmful surfaces or harmful substances, I should say, in the blood while allowing essential ones like oxygen, glucose, and some medications to kind of pass through. So I got this little image up there, okay, to kind of give you a visualization of how it could look. It's built by tight junctions in between capillary endothelial cells. It has a choroid plexus where spinal fluid is actually made. It has an arachnoid layer, which is part of the meninges. But if the BBB is damaged by infection or inflammation, this is how those harmful substances can get into the brain. And they're really, really hard to remove once they're inside. There's no barrier between the brain and the cerebral spinal fluid, but the CSF's structure limits the movement of bacteria and immune cells. So, some things you kind of want to just make sure you have a good understanding on. The choroid plexus. This is what makes CSF and helps form the BBB. And then there's parenchyma. This is the working tissue of the brain that handles thinking, movement, and body control. Now, BBB makes it hard to treat brain infections because many drugs just can't get past it. So, understanding how BBB works helps us to find ways to really safely deliver medications to the brain and central nervous system. Now, the central nervous system usually is pretty good with resisting infection. But if bacteria or viruses get past that BBB, they will cause serious brain and nerve damage. And that's because the CNS does not have its own immune system to kind of fight back. Now, meningitis, which is inflammation around the brain and spinal cord, um, can be caused by bacteria, viruses, or fungi. But there's also non-infectious diseases like happen from certain medications or certain cancers. With acute bacterial meningitis, the bacteria gets into the central nervous system through the blood, surgical procedure, let's say they're coming in for a cranie, or a head injury, or even from nearby infection from sinuses or dental. There are common bacteria, Haemophilus influenza type B, Streptococcus pneumonia, Neisseria meningitis, and E. coli. There are risk factors, like let's say a patient had a head injury, a brain surgery, or they just have a weakened immune system. Okay. What we may see in the ED before they come to us. It can cause confusion, seizures, or even paralysis. If untreated, it can lead to death or permanent brain damage. For us as surgical techs, we have to understand how infections like meningitis even start, especially after a head or spine surgery. So, this is why we are so adamant about aseptic technique, sterile field safety. If you see it, you say it, okay? Because we're trying to prevent post-operative infections. Any questions so far? Okay. Now, I often get asked, why are children more at risk? Well, they do have an immature immune system. Babies and young kids do not have a fully developed defense. So they're more likely to get infections and they're going to struggle to fight them off. We look at common germs by age group. So for our newborns, group B strep, E. coli, listeria. Your infants, that's from like 1 month to 1 year. We're looking at um, strep pneumonia, Hib, Neisseria meningitis. And then older children to us as adults, Neisseria meningitis, Streptococcus pneumonia, and Listeria. So there are some things to look for. Headache, stiff neck, sore throat, and vomiting. Now, red flags are if like you're bending and it's trouble bending your chin to your chest, okay? Because that's a big one that they'll test for. In older children and adults, it may start with irritability, confusion, and then it'll progress to a coma or even death if not treated early. With Haemophilus influenza or Hib meningitis, it starts in the nose and throat and it spreads to the ears, into the sinuses, into your blood, and then it can reach the brain lining in the meninges. Now, it's still unclear how the bacteria passes into the brain via the with the blood-brain barrier there. So they're still looking that up. Now, the risk of age would be under 3 months. Um, Usually protected by mom's antibodies. 6 months to 1 year, the protection does fade, so then the risk does increase. And there are complications, up to 90% death rate if left untreated. And there's long-term effects. It can cause hearing loss, vision issues, seizure, brain swelling, and developmental delays. So, this is why we're always like, time is of the essence. Fast treatment, especially in infants, reduces death and long term damage. Our role is to just understand what we need to do in key emergencies. A lot of times we'll have to put in a shunt placement for brain swelling. So we'll drill um, a hole into the brain. We'll take a tube and kind of have it go down the side into their belly, and that'll drain the extra fluid um, of the brain into the belly. Okay. Or they'll do a spinal tap just to make sure that, okay, this is what we indeed have. I want you to think about this. Mom's protection fades after a few months. The baby's own immune system isn't strong enough yet. This is why the chapter talks about vaccines and early care. It does matter so much at this stage. Okay. So I talked about the spinal tap. We're grabbing a sample of that cerebral spinal fluid. We want to make sure this is indeed what we're working with. It's going to help identify the bacteria in the bloodstream. But we're not done with things trying to get into our central nervous system. There are fungal and parasitic meningitis. Fungal meningitis is the most often cause of what's called cryptococcus, which leads to chronic long-term meningitis. There are other fungi. This includes histoplasma, blastomycosis, you can get from soil, and candida, common in hospital-acquired infections. Develop slow, unlike the fast onset. Our at-risk patients are going to be the ones that already have a weakened immune system, HIV, AIDS, and our organ transplant patients. With parasitic meningitis, it causes a brain infecting amoeba. Yes, you heard it correct. You've got a worm rolling in your head, and it's called Naegleria fowleri. I think I said that right, fowleri. Now, it actually enters through the nose. This is often during swimming in warm, fresh water or improper use of a neti petty with contaminated water. It's not spread by drinking water or salt water. Okay. What happens is the amoeba travels into the sinus to the brain through the nasal passage. So you just want to stay alert. Know that fungal and parasitic meningitis can affect our high risk patients, especially those with immune issues. So you always want to make sure that your surgical irrigation solutions are sterile, which we do anyway. And that's going to help prevent candida related infections from even getting into our patients and even in ourselves. Okay. Now, with fungal meningitis, usually caused by cryptitis, also called candida, who's at risk? It's going to be mostly our immunocompromised patients. HIV, again, organ transplants. Now, how does this differ? Again, slower over time. Okay. The biggest thing that I want you guys to know is that we always sterilize our instruments and solutions correctly, especially to avoid candida infections in the operating room. And our patients are educated. Now, with encephalitis, we're talking about inflammation of the brain. It's more dangerous than meningitis, believe it or not, and it can cause serious neurological problems or death. Now, this is often caused by viruses like herpes simplex or intraviruses. But others could be a retrovirus, which is spread by mosquitoes and ticks, and rabies, which is the lysovirus from animal bites. And we're going to talk about rabies later. But the main two to know: herpes simplex encephalitis, which is the most common in the United States. It's deadly if it's untreated and up to a 70% mortality. Paralytic poliomyelitis, where the motor neurons are attacked and that leads to paralysis. Again, rabies encephalitis causes Lassa from bites by wild animals. It could be bats, it could be raccoons. We just hear more from bats. Now, the virus has a bullet shape underneath a microscope. So we have to stay alert for these neurological symptoms, especially in our high risk patients. And you want to really understand or be aware of an animal bite history because rabies needs urgent treatment. Okay. Once the symptoms appear in rabies, it's usually too late. I know of one case, there may be another one of a survivor because usually it's almost 100% mortality. But there was one survivor, and it was because they put her in a coma once the symptoms started to show, and she survived. Now, we get back to that prion disease, Cruciate-Jacobs disease. It's not caused by bacteria or viruses. This is caused by misfolded proteins called prions. Remember that the prions will fold and they damage the brain, making normal brains proteins fold too. Go back to that. If you visualize had the green square and the circle, and then the square went over and changed the circle to square, that's kind of what's happening. The thing is, prions are not live, but they can still spread in the brain and are very hard to destroy. I want you to think of it like this. Prions are like bad influencers. They don't multiply like germs, but they can cause a lot of chaos by changing how healthy prions actually behave. Now, Crucifix-Jacobs disease is the most common prion disease in humans, and that's very important to know because it attaches the brain. It causes fast decline in memory, movement, and even thinking. It's rare, but it's always fatal and usually progresses in just a few months. Now, even if you never see a case, you must know how to handle instruments safely if prion disease is suspected because it can pass. A couple more diseases that we're going to talk about. We look at bacillus. It is a bacterial infection that can affect both the heart and the central nervous system. Other names you might have heard would be Malta fever, Mediterranean fever, and fever of Crete. Because the fever comes and goes, it's an indolent fever. But there's gastric ruminant fever as well when the stomach symptoms are actually present. Now, with acute bacillus, we're talking about flu-like symptoms, fever, fatigue, and muscle aches. There's weight loss, abdominal, joint, and back pain, but it usually goes away with antibiotics. Chronic bacillus can look like tuberculosis, so there's recurrent symptoms over months or years. This is one you have to look out for, i.e., endocarditis, infective endocarditis. Remember, that is a serious infection of the heart valves, but it can also lead to meningitis and encephalitis. Now, with the brain abscess, this is a pocket of pus inside the brain. It's usually in the frontal or temporal lobes, and it can be either free floating or surrounded by a capsule. If it's in the frontal lobe, sometimes ENT will be called in. Like I've had cases where there was an abscess and we weren't sure if it was in the sinus tract or if it was in the frontal lobe. So ENT would go in first if we got the abscess out and we see all the mucus come out. We're excited because then neuro doesn't have to come in. If we aren't able to get it out, then of course neuro would come in. Okay. Now, what causes it? It usually starts as an infection somewhere in the body. Middle ear, otitis media. It could be sinusitis. It can be mastoiditis, which is an infection of the bone in the ear itself. Tooth abscesses as well. Heart or lung infections. You may see the patient complain of a headache, vomiting, fever. A lot of times they'll come in with confusion or trouble staying awake. And then there's localized symptoms like weakness or numbness, focal neurological signs as well. And we're always looking for ICP, increased pressure in the brain, because we would have to go in and um, do a craniotomy to relieve that pressure. Okay. Now, we look at skin and internal tissues. We have what's called an abscess. Kind of just talked about the abscess in the brain. We have a pocket of pus. It forms due to some type of infection, but here we're talking about under the skin. You'll see red, swollen, warm. It can be painful. This is going to be common in our patients, especially if there's a wound infection or a post-op complication. So they'll come in and they'll say, Samantha, you're going to be scheduled for an I&D. Okay, that's just an incision and drainage. Simple, but it is a very essential and important surgical procedure. Gas gangrene is another big one where now you're looking at deadly infection of soft tissue and muscle. You'll see black, necrotic, dead tissue. You'll have what's called gas bubbles underneath the skin, swelling, and a foul smell. Again, we'll go in and remove as much of the tissue. And then there's systemic infections involving the spread of pathogens throughout the entire body. MRSA, you will see concepts coming up on the coming final on what that is. Methicillin resistant Staphylococcus aureus. It has developed, unfortunately, a resistance to many antibiotics, especially methicillin and related drugs. Unfortunately, it spreads in healthcare settings. We also talk about skin and internal tissue infections and fungal prevention. Fungal infections and surgical site infections prevention is a high yield. They show up on tasks, but more importantly, they show up in our jobs. So, as an ST, we are the key player in just keeping the operating room sterile and safe. Now, Tinea pedis, athlete's foot, is a common fungal infection between the toes. So the patient will have like itching, peeling, scaling skin, and it's confirmed by microscopy, which shows fungal height or like thread-like structures. Now, though it's mild, untreated cases can spread or complicate wound healing. There's Candida albicans, which is yeast. It normally lives on our skin or in our body. But after, let's say, broad spectrum antibiotics, normal bacteria are just wiped out and it allows that candida to overgrow, especially in warm, moist areas. So it can affect skin folds, our surgical wounds, or lead to deeper infections in vulnerable patients. All right. Now, the last thing we're going to be able to do is talk about our recall application and analysis concept that you will potentially see this week if you hadn't already taken your knowledge check and your quiz. So, first concept is going to be recall. Okay. What does the term hemopararis refer to in clinical practice? Kind of think about it in your mind, kind of picture what the options could potentially be. Now, for the application, a patient is brought to the operating room with a history of a recent cerebrovascular accident. During the perioperative assessment, the scrub tach notes that the patient has reduced strength on the right side of the body. Which term best describes the condition? And now we go to the analysis question. A student is comparing different neurological terms. After reviewing symptoms such as decreased activity, CSF sampling procedures, and anatomical locations, the student evaluates which condition specifically describes partial weakness affecting only one side of the body. What is the correct term? So you have A, weakness of paralysis of one side of the body, often seen as a sequel to a stroke, or B, a procedure to obtain cerebral spinal analysis. A or B? Which one do you think it is? This one I kind of made a little bit easier. It is A. That is the clinical term for weakness or partial paralysis. So once you know what hemophilia is, then it'll kind of like click everything into place. So no matter how that concept is asked, you'll be confident in your answer. Here's concept number 2. A diabetic patient has necrotic, foul-smelling wound with gas visible on imaging. Which diagnosis is most characteristic of this presentation? So you're already kind of having in your mind which one it would be. Okay. Application. During perioperative assessment, the team reviews imaging that shows gas bubbles in soft tissue of a patient's foot. The wound is black, it's malodorous, and rapidly worsening. Based on these findings, what condition should the scrub tech anticipate? Okay. Now let's get an analytical question. A student compares four possible conditions: necrotizing fasciitis, gas gangrene, cellulitis, and osteomyelitis. After analyzing the presence of tissue necrosis, foul odor, and gas formation, which diagnosis best describes this combination of clinical signs? So we have our options. Is it necrotizing fasciitis or gas gangrene? Now, I grabbed this one because this is one that sometimes gets everyone just a little bit. And the reason being is because the question is, the answer is actually gas gangrene. I'm going to explain to you why. Gas gangrene is characterized by rapid tissue necrosis, foul smelling discharge, systemic toxicity, and gas production in soft tissues. It's visible in image as gas bubbles. But a lot of people usually pick necrotizing fasciitis, which is rapid and severe, but gas is less common. So that's the trigger word. Okay. Um, it's less commonly presented than in gas gangrene. So it's one of these like both of these are pretty close, but the question's asking the best option. The NBSTA does do that. So you have two options that are pretty close, kind of like a 50-50. Okay. Um, but here you would kind of go just by what is really the difference between necrotizing fasciitis and gas gangrene, and what are the different questions asking. Okay. All right. We talked a lot about cardiovascular, central nervous, and even some that affect the skin in tonight's live session. For those of you who are watching this archive, how do blood pathogens impact patient care and surgery? What are key measures to prevent blood transfusion contamination? And how can knowledge of cardiovascular and central nervous system infections improve surgery outcomes? We're getting closer and closer to the final. So if you guys have any questions, concerns, do not hesitate to reach out. What questions do you guys have for me before we get out of here? None? All right. With that, I want you guys to have a safe and wonderful weekend. Make sure you're eating all the wonderful food, spending time with your loved ones. And I look forward to seeing everyone who can attend next week, week 9, y'all's live session. Happy Thanksgiving and good night, everyone.